Okay, good afternoon, everyone. We are going to go ahead and get started. I want to thank everyone for joining. This afternoon, we are going to hear from Dr. Deepa. She is an assistant professor in the Department of Pediatrics at Emory University School of Medicine, and she's going to be going over giving you an overview of NAS, and then I will walk you through the results of the Vendée audit that many of you did last month. You've gotten your hospital-specific reports, but I'll walk you through the averages for the collaborative-wide. And then we'll also, Dr. Deepa will take you through how to develop performance measures around the SMART aims that you've sent in. So with that, Dr. Deepa, I will turn it over to you. And you should be unmuted.
Thank you, Katie.
Yeah, there you go. Thanks.
Hi, can everybody hear me?
Yep, we can hear you.
Okay, good afternoon. So as Katie said, I'm just going to be talking to you today, Katie, about so we're going to the next step, and we're looking at the effects of in utero exposure to opioids and drugs of abuse. You know, so far we've heard about the epidemiology, and it's a more kind of more broad overview and looking at it from a population perspective. And now I'm just going to be talking more kind of on an individual clinical perspective. So next slide. So it's always nice to begin with it's helpful to look at the history of a problem to provide some perspective. So I've just, shown you this timeline of neonatal abstinence syndrome and marked out, like in green, some of the specific points. And, it was in 1804, morphine was first isolated, and then heroin was synthesized in 1874. And initially, after that, they saw a lot of addiction, especially in women. And initially, it was thought that morphine causes sterility in women, so they didn't really think that, babies were going to show any signs and symptoms. And then the first reported case of neonatal withdrawal was seen in 1875. And then in 1903, they actually were able to use morphine to treat an infant. And then, as you can see, 1967 and the 1990s, 2000s, more and more and more drugs came along. And you see in 2002, there's the first reported case of NAS due to OxyContin. So this is just a brief timeline of where we started and where we are. Next slide. So additionally, before 1970, it was just morphine and heroin. And again, like we saw on the timeline, today you have so many more drugs that are causing these signs and symptoms in babies. Also contributing to this increase is medication-assisted therapy with methadone and buprenorphine, which is essential. It's very important for the mothers, but you also see many more of these infants being exposed to it. So it's much more common and much more complex with the increased use of all kinds of drugs, both illicit and licit drugs. So this all causes additional social, economic, and healthcare costs on society, which we heard about in the previous webinars. Next slide. So one important thing to remember is the mechanism of placental drug transfer, because, this is how the drugs are getting into the baby's body, through the placenta. So if you look at the placenta, there are four main types of placental drug transfer. There's simple diffusion, where something just goes across the placenta from one side to the other. Then there's what's called facilitated diffusion using a carrier, which is shown in B. A carrier molecule carries this across. And then third, there's active transport using ATP, so there's some energy involved, and it can go against a concentration gradient. And the fourth is pinocytosis, where you have something that kind of engulfs the substance and carries it across the placenta. The reason it's important to know this is different drugs get transported across the placenta in different ways. And again, with respect to that, there are some factors that affect the drug transfer across the placenta. They can be physical or pharmacological. So some of the physical factors are mainly to do with the placenta, the placental surface area, the blood flow, the pH of the blood, the uteroplacental flow, the placental metabolism, and each of these things vary from, pregnant woman to pregnant woman. So that affects the drug transport across the placenta. The second big factor is the pharmacologic factors, that is the molecular weight of the drug itself, its lipid solubility, its protein binding, all these things, the concentration gradient across the placenta. See, these are all factors that affect how the drug gets from the mom to the baby. Next slide, please. So looking at opiates and placental drug transfer, so most of the common opiates are low molecular weight, they're lipophilic, they easily transfer across the placenta, and one important point to note is the transmission increases as gestation increases. And again, that probably has a lot to do with the placenta, the placental factors. And synthetic opiates cross more easily than the semi-synthetic ones. And again, combination of drugs, combination of cocaine or heroin with methadone further increases this permeability. And the another factor is that in the baby itself, the ease of transfer across the blood-brain barrier of the fetus with the prolonged half-life in the fetus causes worse withdrawal in infants. So what is NAS? What is this abstinence syndrome? It's a sudden discontinuation of prolonged fetal exposure to opioids. That's what causes this abstinence syndrome or this withdrawal syndrome. Next slide. So now looking at the pathophysiology, so now we know what are the factors that are causing this transport from mother to baby. So the pathophysiology is complex in neonates because their neurologic development is still impaired, still functioning. There's an impaired processing, and there are complex placental pharmacokinetics. And then opioids act through opioid receptors, which are present extensively across the central nervous system. They're also located extensively in the peripheral nervous system, in the gastrointestinal system, and various other systems. And that is the reason you see all these clinical signs and symptoms that we do. And the density and affinity of some of these opioid receptors in neonates is as strong as it is in adults. So that's another important thing to remember. So what happens is these opioid receptors have been in a chronically stimulated state when mom has been using the drug. Suddenly there's a lack of opioids, so this increases the activity in the receptors. It leads to increased adenylate cyclase activity in the cells, and basically it causes all this neurotransmitter imbalance, which I'm going to show you in the next slide. So this is a schematic of what's happening inside the cells. So I just described to you what's happening in the central circle, right? There's the chronically stimulated receptors, the adenylate cyclase. So there's a cascade of things that happen, and there's release of neurotransmitters. So these neurotransmitters are the key points which determine the various signs and symptoms. So you have increased noradrenaline, which is shown on the left in the purple circle. So that causes a lot of the signs and symptoms, including hyperthermia, hypertension, tremors, and tachycardia. Then there's acetylcholine increase. That's the parasympathetic system. So you have diarrhea, vomiting, yawning, sneezing, sweating. Then you have corticotropin increase, which is shown on top. That causes increased stress and hyperphagia. And then on the bottom in blue, it says other receptor activity increases. Then there are two other things that are decreased. Shown on the left, the serotonin decrease, which causes sleep deprivation, sleep fragmentation. And on the right, you see dopamine decrease, leading to hyperirritability and anxiety. So this is what's happening at the cellular level. Next slide. So all of this translates into the clinical signs and symptoms. So there's increased noradrenaline, there's increased acetylcholine, there's increased corticotropin, there's decreased serotonin, and decreased dopamine. So just, this is what is causing all these signs and symptoms. So you have tremors, irritability, excess crying, diarrhea, sometimes seizures. Then you have irritability, jitteriness, tremors. Then a hallmark is hyperirritability, which can lead to agitation, difficulty sleeping, and inconsolable crying. And I'm sure all of you have seen this who have dealt with kids with this problem. They have high-pitched, uncontrollable, excessive crying, and all these are, again, from these neurotransmitters. You have tremors, exaggerated mororeflex, hypotonia, myoclonic jerks. One important thing is you can have seizures from the withdrawal itself, and sometimes they may look like, proper seizures, and if you don't suspect withdrawal, you may think the seizures for another reason. Seizures do occur in 2 to 11% of these infants. Then there is dysregulation and instability of the autonomic nervous system, and that's why you get impaired, different abnormalities of heart rate, respiratory rate, muscle tone, and all these are due to the cholinergic stimulation. Another important point is these may persist for months or even longer, especially if maternal buprenorphine has been used. Next slide. And just continuing for some of the other signs and symptoms, sometimes they abuse inhalants, so you may get a chemical odor. You can mistake it for respiratory distress because they present with respiratory symptoms, and you can say, think it's respiratory failure. Then they can get hyperthermia, but usually it's not a very high fever. There, of course, is poor feeding, excess motor activity, vomiting, diarrhea, poor weight gain. Then I thought this was an important point. So sometimes there's non-central nervous system causes of increased irritability and agitation because there will be severe skin excoriation secondary to the severe loose stools. Or sometimes they are making excessive motor movements, and you can have skin excoriation which is causing them to have increased irritability and agitation. So these are things you have to specifically look for. Another thing is the hyperphagia, which is widely recognized. And, typically most of these infants need about 120 kilocalories per kg per day, but some of these infants, because of their hyperactivity and hyperphagia, may take even 150 calories per kg per day. Next slide. So another point to make is that preterm infants are a little different. You don't see the incidence and severity of withdrawal is less extensive in them. Now, why is this? There are various factors. Remember I told you that that it crosses the placenta, like as gestation increases, there's more that crosses the placenta. So there's decreased cumulative exposure in preterm infants, decreased transmission, there's decreased clearance. So it doesn't go away so quickly. So the receptors are not in such an hyperactivated empty stage as the older kids or the full-term infants, Then there's decreased excretion because of immaturity of the kidneys and liver, decreased fatty tissue in which it accumulates, decreased receptor development, and decreased receptor sensitivity. So it is important to remember that preterm infants, you may not see the full spectrum. Next slide. Then the next point I would like to make is the onset, duration, and frequency. Now, it's important here to remember that each of these drugs, due to a lot of the factors that I mentioned before, the transfer across the placenta, their pharmacologic makeup, like their molecular weight, etc. So they can have different onset, duration, and frequency. So different drugs have a different onset, duration, and frequency of NAS. So it's important to keep in mind. For example, in heroin, it's earlier and lasts, it doesn't last as long. Whereas methadone and buprenorphine, you can see it comes later and it can last much longer. So one key thing to remember is that withdrawal presentation differs by exposure. So it depends on the drug. So you have to monitor the infant for signs and symptoms of withdrawal according to what the drugs they have been exposed to. So that's a very key point to remember. There is no one-size-fits-all. There is no saying start monitoring at this time, end monitoring at this time. It doesn't work that way because each drug has different. And the combination of drugs can make it even more complex and complicated. So, next slide. And again, the course, the severity and intensity of the course are modified by various factors. So term infants, bigger birth weight infants, the severity and intensity is likely to be higher. Polydrug abuse, I already talked about. Combination of drugs with benzodiazepines. So So sometimes you can see this like two phases. The initial phase, you may have short and intense tremors, seizures, irritability, feeding problems, vomiting, diarrhea, and all these signs may last for 1 to 2 weeks. But then you can have a long chronic and relapsing course, including hyperirritability, sleep disturbances, hyperphagia, and other neurologic and autonomic signs, lasting for a few weeks to a few months. And then there are a lot of studies that have even done, looked at these infants a while later, and some studies have shown some lasting effects. But it's not very clear if that's due to drugs itself or due to the circumstances in which they're growing up. But, the main thing is that you can have two phases. Then it's not just done and gone as soon as you they're okay and you send them home. So that's another important point to remember. So so far I just wanted to give you an overview of what these drugs do, why they do it, what's happening on the cellular level, what's happening in the body that causes them to have these signs and symptoms. And it's very important to remember different drugs, different combinations of drugs show different signs and symptoms that may start at different times, end at different times, and you can have a short course or a prolonged course. Next slide. Just a brief mention of non-opiate withdrawal, because there are a lot of drugs now that have come into play and that we are seeing some of the babies being exposed to who show different kinds of withdrawal. And one common thread you'll find here is the neurotransmitters that I talked to you about and showed you. So selective serotonin reuptake inhibitors that are taken usually for depression. Again, these symptoms are from excess serotonin and noradrenaline. Then tricyclic antidepressants is mainly to the cholinergic system. Then benzodiazepines, you have methamphetamines, and then inhalant withdrawal. So these are non-opiate withdrawals that we are seeing a lot more of now. Next slide. So having said all this, this slide is just to show you that, we are saying neonatal abstinence and focusing on opiate withdrawal. But the thing to remember is that all these different drugs by themselves and in combination have so many different effects on the growing fetus that can affect them in the womb, it can affect them when they come out, and they can affect them for quite a while after that. So you have the opiates, you have the tobacco, the alcohol, stimulants, cannabis, and all of these have different effects. So it's very important to keep in mind the whole spectrum and not just focus on one drug or one mechanism. Next slide. The other very important point that is again an overview is to remember that the fetal drug exposure affects them not just directly by crossing the placenta and affecting the fetus, the developing fetus, but it also has tons of effects on the mother, affecting her cardiac system, her uterus, her kidneys, her lungs, and all these can compound the drug effects directly on the baby. So all these, if you look at, like it can cause vasoconstriction, placental insufficiency, and placental abruption by affecting the placenta. It can cause pulmonary edema and breathing problems by affecting the lung in the mom. So these are, add to the effects of the drugs that the drugs directly have on the fetus itself. So it's very important to keep these factors in mind while looking at a baby and a mom, looking at the mother-infant dyad, and taking all these into consideration. I think that's it. Yeah. So that's it for the first part, and I'm happy to answer any questions. My apologies if I went a little fast, but I'm happy to answer any questions.
If you do have questions, you can press *6 to unmute yourself, or you can use the chat box.
So I hope everyone's got a good sense of what it is these drugs do, how do they do it, and the importance of, the polydrug picture, the overall effects on the mom as a whole, the combination of drug effects, and the importance of it's not a one-size-fits all. I think those are the main points I wanted to convey.
Thank you. That was a great overview. I am now going to give us just a high-level look at the Vendée audit results from what you all submitted last month. As I mentioned at the beginning, you should have your individual hospital report. If you don't have that and you participated in the audit, please let me know that. I don't have your individual results. I just have the overall summary. So I'm going to walk through that, and it might give you some ideas for where your hospital wants to focus as you compare yourself with the rest of the collaborative. So, okay, so we had 38 hospitals participating, which is about 80% of the collaborative. And I should point out that Vaughn really applauded this participation rate. They said for the first time doing this, that this was pretty high participation. So we were excited about that. And the hospitals that didn't do it, there are various reasons why. And I did just want to make a note, too, that if you didn't participate and your hospital wanted to, I think I've spoken with all of you, but you are able to take their instructions and go back and do it on your own so that you can still have that baseline data for yourself. There were 16 hospitals that audited 34 infants in the 3-month window that we were using. And I wanted to highlight first in the section on policies and guidelines, these are really more of those structure measures. As you remember, it asked about policies and guidelines for using Eat, Sleep, Console, non-pharmacological treatment, pharmacological treatment, and encouraging breastfeeding, and then also having an education program standardizing NAS scoring. These percentages were all under 55%, so for all of these, less than 55% of hospitals reported that they have this, and the two lowest being the formal education program for standardizing NAS scoring, and then guidelines and policies for using Eat, Sleep, Console. So those might be areas that you consider making measures around. This slide is showing you more of the demographics. This is, I think a little bit as expected, although we did note that it looks like there are more transfers than we had potentially realized. And then also 100% of the babies were scored for NAS. When we look at non-pharmacologic care, there was only one infant. There was only one infant actually that was assessed using ESC prior to initiating pharmacologic treatment. There was also only 14% who received any of their mother's own milk prior to discharge. This is probably as expected, but morphine was the most common pharmacologic agent administered for treating NAS, with methadone being the second highest. And then this is one of the box and whisker plots showing the total duration of pharmacologic treatment. As you can see here, there was pretty wide variability in the duration, with the max being 75, the minimum being 2, and then 50% of you all reporting that it was between 9 and 23 days with a median of 13. For total length of NICU stay, there's also a wide range, but not a lot of variability. So the range was between 2 and then 77 days. The median was 18, and then 50% being within 10 and 24. And then for total length of hospital stay, the median was 22 days. Again, the max 77, minimum of 7, and then 50% being within 32 and 15 days. So that is really all that I had in terms of going over the Vendée audit. Are there any questions about that? If there are, you can, again, press *6 to unmute yourself, or you can use the chat box. Okay. Well, if you think of any, you all know how to contact me, or you can ask me towards the end of the webinar. But now I wanted to go back and have Dr. Deepa move through some of the quality improvement component of this.
Hey, Katie, thanks. Can everyone hear me?
Yes, we can hear you.
Okay. So, thanks for that overview. And, yes, congrats. I think, for Vaughn to say the participation was huge, that is huge. So congrats to everybody. Let's just, keep going on. I think this is going to be a fantastic project. I'm very excited. So, I just wanted to bring us back to a little bit of our QI. Every webinar we like to kind of end with a little QI. And this is just a recap of what we have talked about before, what I told you before. We have what's called the model for improvement, and there are 4 components to it, 4 key elements. First, what are we trying to accomplish? We come up with an aim. How will we know that a change is an improvement? That's the measure. What changes will result in an improvement? That's the process improvement tool. And then we want to test it. So the test of change, one of the ways to do it is the Plan, Do, Study, Act, or PDSA. So this is the model for improvement, which I had talked to you about earlier. Next slide. So just to recap, now there were 7 steps, and the first step, and I'll bring it back later, the first step was forming a team, which we talked about, and I think almost all of you have done by now. The second was coming up with a SMART aim. I discussed that with you, and I think we do have some people who have sent in their SMART aims and others who are still working on it. But again, I just wanted to recap a little bit. So the SMART 8 template, one of the templates was we will change, increase or decrease a specific thing among a specific population from X to Y by so-and-so date. So this is an example of a SMART aim. So next slide. So one of the SMART aims that I think one of you guys had sent in was we will increase the percentage of drug screens obtained on infants born to at-risk mothers from 85% to 95% by July of 2021. Next slide. So this is, it's a specific, measurable, achievable aim. You're having a specific goal. You're able to measure it from 85 to 95% a change. It's achievable. Next slide. And it's relevant, and you have a defined population, infants born to at-risk mothers. Next slide. And it's time-specific. By a specific time, you're going to make this change. So this does have all the components of the SMART aim that we talked about. Next slide. And this is what I was saying. So now we've talked about the first 2 steps. So I just want to talk a little bit about the third step, that is the establishing measures. Next slide. So what is measurement in quality improvement in healthcare? So there's a maxim, there's a saying, you can't manage what you don't measure. So you have to be able to measure something to be able to manage it. So the goal of measurement in QI in healthcare is to understand a process quantitatively so that you can provide interventions to improve that performance. So then what you want to do is apply the intervention, then use a measure, use a metric to determine the effect of the intervention, and then monitor and measure that over time so that you can say, okay, this is what we did, and it went from so-and-so to so-and-so. So you're actually measuring something. So there are a lot of different models for measurement in healthcare, and one of the models which I like is what's called the Donabedian model. And so you take into account structural measures, and they give you some examples of that, the infrastructure, the demographics, the technology, etc. Then you take into account process measures. So you look to measure things like diagnosis, treatment, etc. And then the next one is outcome measures, where you're measuring the outcome of what you're doing, which may be mortality, morbidity, etc. So this is just one model. Next slide. So it's important to have a measurement strategy. Why? Because it's important to have that data to determine whether the changes you are making are in fact leading to improvement. It's very well and good to say, oh, you know what, if you do this, this is what's going to happen. But you have to be actually able to measure it and say, this is what it was before, this is what I did, and this is what the outcome is. Actually measure it and quantify it to say, this worked, or this actually led to the improvement. So here I've just listed again some of the types of measures which we saw briefly in the Donabedian model. So you have structural measures. So what are structural measures? Are all factors that affect the context in which the care is delivered. So you can, for your project, for your thing, it may be some technology that you're using in your facility that you may want to do something about and use to make an improvement. So you have to be able to study those structural measures. Then process measures are related to the processes you are working on as part of this improvement. So is it a diagnosis? Is it a treatment? Is it a process of care? Some process that you're doing that you think will lead to improvement. Then the third measure is the outcome measures. So it's tied to the overall aim of the project. So you're looking at mortality, morbidity, cost, and in our example, in our overall aim, we said we're going to decrease the length of stay. So that's an outcome measure. One important point to remember is that outcome measures can take a long time. Then the fourth thing is what is called the balancing measure. So you want to help ensure that by improving one part, you're not, doing something bad to another part. For example, by trying to reduce a patient's length of stay in the hospital, you don't want readmission rates to increase. So that's what's called a balancing measure. Next slide. So looking at the SMART aim, for example, that I showed you earlier, we will increase the percentage of drug screens obtained on infants born to at-risk mothers from 85 to 95% by July of 2021. So what could be some of the measures that you could look at in something like this? Next slide. So the process measures would be obtaining urine drug screens. You can examine that. You can examine that carefully, how they do it in your facility, how you can improve it. So you can take that and measure that to study the process. The outcome measure would be identification of newborns at risk for drug withdrawal. So how can you improve that outcome? How do you measure that outcome? Then press it again. Press it again. So the balancing out measures here would be you want to decrease the false positive, false negative drug screens. Once more. And then one additional thing that you have to keep in mind, it's important, it doesn't always happen, is the patient or family-centered measure, that is infant discharge to mother's care. So let us look at this like in one by one. Next slide. So process measures. So you have to see, is the process happening as planned? So you must find a way to track and document whether this process is happening as you have defined it. For example, is the urine drug screen in the at-risk infant being done? So if mothers have a history or mothers have a positive urine drug screen, are you able to track and find out that those urine drug screens are actually being done in these at-risk infants? So that's a process measure. Next slide. So an outcome measure, how would you look at that? Is the intervention having the desired effect? So by increasing testing, are you increasing the number of newborns actually identified? So you have to come up with some clinically relevant concrete data. So most QI projects should have at least one outcome measure, but again, like I told you before, some of these outcomes take a long time. So you have to balance that out. Next slide. So again, I talked about the balancing measure. Are there any untoward consequences? So you may increase the drug screens, but is there a chance that you're increasing the false positives? So try to anticipate these possible outcomes. You may or may not be able to, but sometimes something will strike you that you haven't even thought about. So just keep your mind open to look for those things. Next slide. And I talked about family-centered measures. So, and again, this doesn't always happen. Sometimes it's hard for it to happen. But for something like this, you can think of, providing skin-to-skin care or mother providing own breast milk as one of a measure that you can look at, which is a family-oriented or family-centered measure. Next slide. So I just kind of, gave you a brief overview, like I said, of the next step. If you come up with a SMART aim, you have to look at what you're going to measure, and you have to keep these measures in mind: the structure, the process, the outcome, and the balancing measures, and if possible, the family-centered measures. So let's look at some of the other SMART aims, right? So one is we aim to decrease the length of treatment time among infants diagnosed with NAS who are treated with pharmacotherapy from so-and-so to so-and-so by April 2021. So what kind of measure would this be? This would be an outcome measure. Then the second example is you will educate at least 85% of the staff, or something like we will increase the number of staff who are educated from 80% to 90%, something like that. So this would be, I would consider this a process measure. You're, getting the process of improving identification and outcomes for NAS babies. This is just a very, very brief overview and something for you to think about while you have been working on your SMART aims and come up with it. This is the next step in the model for improvement. I'm going to stop here, and I'm happy to answer any questions to the best of my ability. Thank you.
And again, just a reminder that you can press *6 to unmute yourself if you have a question.
Or feel free to put something in the chat box.
Yes.
Hey, this is Rachel Fullard from Kennestone. I have a question regarding pharmacologic management. What determines if a baby is exposed to long-term methadone, if you treat that baby's NAS with methadone or morphine?
So it's typically not the drug that has been used that determines that. As we saw in our Bondi audit, and which is true across most of the country, the first line is morphine, but there are more and more studies showing that methadone does have a lot of benefits. So you might find that methadone may be the drug of choice more, in some time. So those studies are things. So it's just so far. Studies of, morphine has been the drug used. It's then after that methadone has come into play. So it's not what the baby has been exposed to, but what the the center uses. Some centers use methadone, very few, but some centers do use methadone as the first drug of treatment. So that's really what it is. I mean, before people used to use all different kinds of things like paregoric and all that, but now it's literally like morphine, methadone, and of course, to recalcitrant therapies, they do add clonidine, and sometimes when there are seizures and things which are a problem, they have used phenobarbital.
Okay.
But thank you for your question. Anybody else? Oh, I see something in the chat box. Oh, you're so welcome. Thank you. I appreciate that. You are welcome.
Thank you, Dr. Deepa. That was a great overview of both NAS and how to develop measures. As everyone's starting out on working on their SMART aims and then developing measures from that. While y'all are thinking of any questions, I'm going to go ahead and go over just a few housekeeping items. So this is just a reminder. We have sent out a plan, if you will, for watching the Vaughan micro lessons that most hospitals are following. I will say some of your hospitals have chosen to move at a different pace, and that is perfectly fine. But if you're following the schedule that we've sent out, you'll watch the second micro lesson this month, and it'll correspond with the information that we've gone over on this webinar. And then also, as you know, you'll be getting monthly reports showing how many of your core members from your hospital have completed which micro lessons. You'll be getting this very soon. Vaughn actually sent it to me just yesterday afternoon, and for some reason my computer won't let me open the file. So once they get me a version I can open, I'm going to share that with all of you. But also kudos to you all, because they said that we are doing a great job getting everyone started. They were very impressed with it. So I wanted to congratulate you all on that. And then also, thank you for sending in your SMART aims. They were really great to see. I know many of you have sent them in to me either yesterday afternoon or today. And if I haven't responded, it doesn't mean I haven't gotten it. I've just flagged it in my email to go through and compile them all. But we very much appreciate that. If you haven't sent it in, please go ahead and still do so. They're really great to see, and they're helping us know what you all are working on so that we can, target these webinars most appropriately for what it seems like you are wanting to hear about. And then the last thing I'll show you is just a reminder that this is our key driver diagram. So it has on there the micro lesson from Bond that you'll watch this month, and then the interventions corresponding to that along with the primary drivers. So I'll send this out in a follow-up email to everyone so you have it, but I just wanted to make mention of it now. So I see that there's a question in the chat box. We're having issues getting our team logged into Visa Lessons. Angela, I can definitely help you with that. Has anyone else had that problem? Or I guess if you do, please let me know. My first thought of what that might be is that when they did the webinar with us, when Vaughn did the webinar with us, it was on what they call the LMS platform, and then between that webinar and when they got all of you all signed up into the system, they switched it over to the edX system. So if you were following those instructions and clicking on the LMS, that may be a barrier to it working. But if it's not that, I'll connect you with Vaughn and we can figure out what the problem is. But if anyone else is having that problem, please let me know.
Thanks, Katie. And again, I want to congratulate all of you for your participation and looking forward to seeing all the smart aims. You know, Dr. Ravi Patel, Dr. David Levine, and I have been working with Katie together on this, and we're really impressed by what you're doing and just hope to continue doing this so that